I'm Dr. Ken Flegel, editor at the Canadian Medical Association Journal and specialist physician in internal medicine in Montreal, Canada. In this talk, I will be speaking about a particular type of scent sensitivity, asthma caused by exposure to artificial scents in our hospital environments. I will be addressing the following specific topics. First, how much is known about the role of artificial scents in causing asthma? Second, I will cover some arguments that justify scent controls in our hospitals. Third, I will outline some ethical ideas which should guide the change in hospital policy. Fourth, I will give reasons from the hospital and healthcare worker perspectives that mandate change. Then I will highlight the best arguments in favor of a no-scents policy. Finally, I will recommend a series of efforts aimed at hospitals to effect a change in policy. In population-based surveys, between 26 and 30% of respondents report some sensitivity to chemicals. Of all persons with asthma, 27% say that their disease is made worse by exposure to scents. Asthma is present in 8.4% of the Canadian population, but less than half of these cases can be explained by a well-recognized classic allergic mechanism. What is the evidence that artificial scents cause asthma? Some asthma patients report worsening of their asthma by a range of chemicals that are not known to cause classical allergic reactions. Some chemicals are generally recognized to make ordinary allergic asthma worse. More specifically, a new family of tissue receptors called transient receptor potential channels has recently been discovered in the lung airways. Noxious chemicals activate these receptors to release biologically active chemicals called neuropeptides that in turn attract a type of white blood cell called a neutrophil. This chain of events leads to inflammation, airway constriction, and mucus production, which is the very definition of asthma. Finally, persons with a chemical irritant sensitivity report relief from asthma symptoms when they avoid exposure to these chemicals. The scent sensitivity problem would be much easier to solve if there were no problems in establishing a causal link to asthma and other sensitivity-type illnesses. But there are several aspects of the problem which make it complex and difficult to solve, even for any one particular patient. Each person who suffers from any chemical sensitivity is usually sensitive to a select set of chemicals, though it takes time and effort to be sure which chemicals those are. To add complexity, thousands of potential chemical irritants have been added to our environment from the start of the Industrial Revolution, and many new ones continue to be developed and released into our environment. Unlike many other diseases, irritant asthma often has no one specific cause. Furthermore, the specific mechanism for each chemical to cause an instance of disease may also be specific to that chemical. There is a set of arguments that provide strong justification for a no-scents hospital policy. The evidence for health benefit from artificial scents is weak and is not strengthening, whereas the evidence for health harm is good and it is strengthening. The applications of artificial scents is optional, but the exposure to artificial scents is often unpredictable and typically unavoidable. Use of artificial scents has a social purpose, whereas use of healthcare has an individual purpose. Similarly, there is a set of ethical principles from the patient perspective that provide more background support for a no-scents policy. Every competent person has autonomous control over decisions regarding the person, which includes the health of that person. All patients may expect that all healthcare management activities concerning them are intended to provide benefit. Patients can expect to be protected from harm in general, and from harm related to healthcare or the hospital environment in particular. It is also useful to consider the prospect of a scent-free policy from the hospital perspective. As a matter of accreditation standards of hospital medical practice, hospitals have a duty to ensure the competence and health of all healthcare workers. They also have a duty to protect those healthcare workers from undue work hazards, especially biohazards. Hospitals and their entire staff have a duty to protect patients from all hazards. Here is a list of the types of hazards. Staff abuse or neglect or incompetence, other violent or criminal activity, nosocomial or hospital-acquired infections, treatment-related risks, and environmental risks, chemicals, gases, and physical. As it was for the hospital as an institution, there is a similar set of duties for individual healthcare workers. While each one has a measure of autonomy within a job description, each has a duty to maintain personal competence and health. Each has a duty to ensure optimal disease management for each patient. Each has a duty to protect the patient from additional hazard. This includes transmissible infections and unnecessary exposure to chemical, physical, or radiation hazard. In summary, a case can be made for a no-sense policy from each of the hospital and the healthcare worker perspectives. Artificial scents are being used routinely by healthcare workers, other patients, and their visitors. Patients cannot easily protect themselves from being exposed. Patients in hospital these days tend to be elderly, fragile, and ill. Many of them have asthma or other cardiorespiratory diseases. Many of these diseases can be made still worse from artificial scent exposure, leading to serious consequences. I would like now to summarize the best arguments for having a no-scents policy in our hospitals. A number of public events venues have no-scents policies. They have done this in response to public complaints. Some hospitals, including large teaching hospitals, already have no-scents policies. They must know there are good reasons for doing so. There are good justice, ethical, and health benefit arguments in favor of such a policy, whereas the main contrary argument is personal freedom to choose, a non-essential matter at that. There is a high prevalence of asthma in the general population, a good proportion of which is owing to chemical sensitivity. Asthma sufferers, including scent-sensitive ones, are concentrated in hospitals and other healthcare settings. It is fair to ask what we can do about irritant asthma and artificial scents in our healthcare institutions. As it is not a topic that is generally understood, sufferers and their supporters need to organize, speak out, and advocate for control policies. It makes sense to target hospitals and publicly funded clinics. I strongly recommend concentrating efforts on securing no-scent policies from high reputation, high volume institutions, because they tend to be opinion influencers. If they make a change, other healthcare facilities will take notice. An effort should be made to furnish information and fact sheets about the prevalence and harms of scent exposure. We should provide these centers with valid lists of other prestigious centers that already have no-scent policies. Petitioning and demonstration activities are justified. They should pinpoint high-risk parts of hospitals, such as respiratory and cardiac disease clinics, cardiorespiratory wards, intensive care units, and pediatric, medical, and geriatric wards. In summary, scent sensitivity is a prevalent and serious health problem. Although our scientific knowledge about it is still in the early stages, there is no good justification for failing to prevent sufferers from being exposed unexpectedly and unnecessarily. Healthcare institutions should be teaching by setting an example of having scent-free policies. They can be pressured to change by advocacy and public demand. Targeted activities aimed at key health centers and their high-risk units should be part of the effort. Thank you for your attention.